Oh my God. Sorry, y'all. This is so embarrassing. I'm on call, though, so I have to take this. Sorry. Hello?
Dr. Brill, help! I just intubated a status asthmaticus in the emergency department. I'm scared.
Oh, no. All right, Max, it's going to be okay, all right? We're going to go through this together as a team. We're going to save your patient, okay? All right, so I'm Meredith. I'm one of the Pulmonary Fellows, and we're going to talk about status asthmaticus today. So right now, this is probably what the patient looks like on the ventilator. It sounds like this is what Max looks like, too, downstairs getting called about the patient. You walk into the room, and this is what you hear. All the alarms are going off. Your oxygen's going down. Your heart rate's going up. Your blood pressure's going down. Your CO2 is going up. Everything seems like it's going wrong. It feels like somebody just dropped a bomb on your lap, and you have no idea how to defuse it. A lot of ICU calls feel this way, and so I just want to give you 3 simple steps to keep it simple. So what we're going to talk about today is unhook, sedate, and decrease the rate. Can you guys repeat that with me? Unhook, sedate, and decrease the rate. Great. All right. And so the whole point of this is to figure out why this is happening. And so luckily in most asthma patients, all of these problems are happening because of one thing, and that thing is Auto-PEEP. So what I want to talk about today is what does that mean? What does it lead to? What does it actually look like so you can identify it? And then most importantly, how do you get it to stop? So what does it mean? So quite literally, it means self-created positive end expiratory pressure. And why does that happen? So what happens is your patient's having bronchospasm and they can't get air out. This leads to air trapping. They don't have enough time to exhale, and it leads to a vicious cycle, and they kind of puff up like a balloon, just like poor SpongeBob here. So what can that lead to? So you can't get air in, and so you get decreased oxygen. You can't get air out, and so you get increased CO2. And then the most feared complication is that because your pressure is building up in your chest, you actually can't even return the blood to the right side of your heart, never makes it through the lungs, never makes it to the left side of the heart, and that's how your asthmatic patient can die. So because this has such dire consequences, we want you guys to be able to identify it quickly. So this is a cartoon of a flow versus time curve, and I want you to look at the dotted line. That's all of us. Whenever we exhale, we breathe out all the way. We always make it back to our baseline, back to 0. But now look at your asthma patient. They never have enough time to breathe out. They never get out all of their air. And when they're on the ventilator, you're pushing air back into them at a timed rate. And so they trap that air, and that's what Auto-PEEP is. Here's what it looks like on the ventilator. So you can see labeled here is the Auto-PEEP. So that's the flow time curve on the ventilator, and you can see that person's never getting back to baseline. We never give them a chance before we force more air in, worsening the problem. So what you guys probably want to know is how do you get it to stop? All the alarms are going off. You're an extremis, they're an extremis. You just want it to end. So step 1, unhook. People are going to think you're crazy. People are going to tell you, please don't do that. What are you doing? You're going to feel scared. But if you know the physiology, it makes sense. Remember, your patient can't breathe out. You keep forcing air in. What you need to do is unhook them, and that allows them to exhale, and then it gets them back to that 0 line, remember from the graph. But you're going to have to hook them back up eventually, so this is only a temporary solution. So step 2, similar to both status epilepticus and VT storm, you've got to sedate. You need to suppress all of that sympathetic drive. You want to get control, and that's your goal. So you can use anything you have, fentanyl, Versed, whatever's around you. Just know that propofol and ketamine actually have bronchodilatory effects in addition to sedation. And so if you have those available, those are the preferred. All right, so now you hear this guy going off. We all know him. I am not breathing. That's the ventilator alarm, right? So what does that mean? So you unhooked the patient and you sedated them, but you haven't changed your ventilator settings yet, and so you're going back into this Auto-PEEP. You get your blood gas back, and it's 7.080. That is not ideal. We don't like that. The CO2 seems a little high, and I just don't want you to rush to cut this red wire and ramp up that respiratory rate. I know everything in your heart and soul from medical school tells you to increase minute ventilation to blow off CO2. But again, think about what's going on with this patient. Let me show you. That's probably what Max looks like when I tell him. All right, so here's a ventilator. The patient's breathing 26. The number next to that's important. That's the I to E ratio, okay? It's 1 to 2 right now. So what's happening is you have a set time your patient can breathe in, but you're not sucking air out. You rely on the patient's passive exhalation, right? And your patient's bad at blowing out, so they don't have enough time. If you can't blow out, you can't get rid of CO2, right? So here's the same patient. Now we've decreased their respiratory rate to 14, and look, their I to E ratio went from 1 to 2 to almost 1 to 5. And look at their graph. They're almost breathing out for the whole screen, and now you can see they get back to baseline, back to that 0 line, thus relieving their auto-PEEP and getting rid of all of that CO2. So here's your blood gas now, 7.15, 65. Great job. I know that's not ideal, but it's just not going to be. You're going to still struggle, but I want you to remember that the rule for blood gas is the enemy of good is better. So as long as you're going in the right direction, we want you to consider that a success. So now hopefully your patient's resting comfortably on the vent, and now hopefully Max and his intern can also go rest comfortably in the call room. And just remember, when you walk in and all the alarms are going off and it feels like somebody just laid this bomb on you with hypoxia, hypotension, and hypercarbia, you now know how to diffuse it. Say it with me. Unhook, sedate, and decrease the rate. And that's how you can save an asthma patient's life before it's too late. Thank you.